If you enjoy this show, we think you might enjoy our brand new podcast, ACR Journals on Air, featuring interviews, commentary, and analysis on research from our 3 peer-reviewed journals. Join host Dr. Vicky Shanmugam each episode for engaging discussions with author and independent experts about recently published studies, their implications for clinical care, and how they move the field of rheumatology forward. Bookmark acrjournalsonair.org or find us on Apple Podcast, Google Podcast, Spotify, Audible, and iHeartRadio.
Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, Stitcher Radio, and now on Audible and iHeartRadio as well. So I started my rheumatology fellowship 10 years ago, and within that short decade, I've seen amazing advances within the field. There's greater understanding and better treatments for people with autoinflammatory diseases, medications for lupus nephritis, potent oral medications for rheumatoid arthritis, new biologics for psoriasis and psoriatic arthritis, and new and effective treatments for different kinds of vasculitides. However, there's one disease where I don't think we've made much progress. In fact, this disease, which has symptoms that affect most organ systems, I find the one that's most difficult to manage. It's really challenging to diagnose, as there are no specific laboratory or imaging studies that can confirm the diagnosis. And also, medications aren't very effective. It causes significant disability to both children and adults. In fact, children with these disorders are often unable to attend school and may even be wheelchair bound. And adults with these disorders find it difficult to work, care for themselves, or their families. Of course, I'm talking about the chronic pain syndromes. There's many different names for these conditions: pain amplification, fibromyalgia, central pain, and there's many associated conditions such as irritable bowel syndrome, chronic headaches, chronic fatigue, pelvic pain disorders, and perhaps even long COVID that are often associated with chronic pain. With me today to discuss central pain syndromes is one of the grandfathers of the field, Dr. Howard Schubiner. Dr. Schubiner is the founder and director of the Mindbody medicine program at Providence Hospital in Southfield, Michigan. He's a professor at Michigan State University School of Medicine and a fellow in the American College of Physicians and the American Academy of Pediatrics. He has published extensively in scientific journals and has written several books, including Unlearn Your Pain and Unlearn Your Anxiety and Depression. Our discussion today will address how pain syndromes occur, what's actually happening in the brain, how to diagnose these syndromes in our patients, how to explain them to patients, and most importantly, how to help patients on their road to recovery. He has decades of experience in treating patients with these syndromes and backs up his approach with the results of randomized control studies. These studies show that a specific type of treatment actually leads to decrease or almost complete elimination of pain in a large majority of patients with chronic pain. In looking back at my rheumatology practice over the last 10 years, I've been able to diagnose many patients with chronic pain. However, until now, I don't think I ever had the tools to help them get better. But after talking with Dr. Schubiner, I'm now better equipped to guide my patients on the road to recovery. And I hope that after listening to this podcast, you will as well. Howard, welcome to the show.
Thank you for having me. I didn't know ACR had a podcast.
We have two now. This is great. Yeah, this is a great time. And I'm glad you said that. Now you'll be able to tell everybody about our
I
podcasts,
know, it's
both
exciting.
this and ACR Journals on Air, which is
Yeah,
our
that's
newest
awesome.
podcast.
I'm honored, really. I'm really honored to be here. I truly will say that. Anyway, go ahead. Yeah.
Awesome. So we brought you in to talk a little bit about pain and to get a better understanding about what pain is all about. But first, I wanted to ask you how you became interested in studying and researching pain.
Yeah, right. And as an internist, I've done a variety of different things in my career, none of which had anything to do with pain until about 20 years ago. And who wants to go into pain? I certainly didn't. It just didn't seem like a fun topic. And I gotta tell you, I love when patients come in with this chronic and severe pains. I'm happy. It's shocking. I am happy now. And it all started with a book that somebody suggested that I read by John Sarno, who passed away a couple of years ago. Dr. Sarno had these seemingly wild and crazy ideas that the brain was causing back pain. He was a physiatrist, and emotions were causing back pain. And he didn't have the science and he didn't have the studies to prove it. He just had tons of patient success stories, and people loved him as a cult hero, kind of, in a way. He's being bashed now if you read the articles about him, but he was actually right, I gotta say. And the science now has confirmed the vast majority of his approach. And what happened to me is I read the book. I went to work with him a few days. I came back to my hospital. I said to my chair of internal medicine, "Hey, I'd like to start a clinic and, see people with chronic pain." He goes, "Sure, go ahead." And so I just started.
Nobody else wants to see them. Please, Howard.
And I just started talking to people. Literally, I just listened. And I took the kind of detailed and long histories to try to flesh it all out that I had never done before, and most people don't have the time to do.
Yeah. I think these are the patients that, for me in clinic, take the longest to understand. Patients with rheumatoid arthritis, even vasculitis, I sort of understand. And when I speak with patients with chronic pain, certainly there's so much there, not only about pain, but all the other associated symptoms that come with these diagnoses of chronic pain syndromes. Does take a long time to get through the visit. So what did you learn about pain and sort of your understanding of what pain is?
Let me just describe a typical patient for a moment. This is what I learned when I started talking to people. So I would start at the beginning. Francis Peabody, right, in 1929 wrote Caring for the Patient, and he said, you have to look at the whole patient. I said, all right, I'll talk to you. Tell me your story. So someone who grows up with a critical or demanding parent, let's say, and they think that's normal. It is normal for them, of course. They have no symptoms in childhood, maybe stomach aches going to school or something. And then they get to their teens, and then it's a woman, say, whose boyfriend dumps her and sends lewd pictures of her around the school, and her best friend is estranged from her, and all of a sudden she gets migraine headaches. And she goes to the doctor, and they say, oh, you've got migraine. Okay, fine, she has migraine. But no one's really asking what's going on in your life, right? And then she grows up, she gets in her 20s, she marries a guy, turns out to be critical and demanding, kind of like her father. And then she gets irritable bowel or pelvic pain syndrome. And again, go to doctors. Well, you've got pelvic pain, you've got irritable bowel. Okay. Then, this goes on. Maybe he's abusive to the kids or whatever. She divorces a jerk, but he's trying to get the kids against her. He's not paying child support or whatever. And then she gets in a little fender bender accident and her neck starts to hurt. And then the pain spreads from her neck down all the way axially down her back. And then she starts getting pain in her shoulders and in her arms and in her legs. And now she has fibromyalgia. And so at the end, you say, oh, you've got fibromyalgia. Here's the criteria. But if you look at her life and you look at these linkages, it's astounding what you will find day after day after day. And so that's what I learned. And the research shows that stress and emotions cause the exact same changes in the brain as does a physical injury.
Amazing. So you're saying that these early sort of adverse childhood events sort of predispose people to develop these pain syndromes when they later face additional stressors, whether it's emotional or physical?
Yeah, it's well known. ACEs, it's well known that ACEs predispose to a whole variety of things, including chronic pain, including anxiety, depression, obesity, not to mention heart disease and COPD and autoimmune disease, by the way. But
Yep.
it's also well known what changes occur in the brain due to these ACEs that have to do with the adrenocortical pathways, pituitary corticoadrenal pathways. And these are long lasting changes. They go all the way into adulthood. I think of it as kind of a danger signal. If you grow up and you're on edge, you never know what's going to happen, and bad things can happen at any moment. You grow up and you adapt to that. You become a people pleaser. You don't want to rock the boat, and I'm sure, if you again look at your patients, you'll see this. They put themselves last. But this danger signal in the brain then can get activated by the repeated stressful life events. And then the brain, and this is the weird thing, the brain can then generate a wide variety of symptoms that include irritable bowel and pelvic pain and headaches and back pain and fibromyalgia and a whole variety of facial pains and burning mouth syndrome. This huge array of symptoms that seem like they have nothing in common, but they're all the same, which makes my life kind of easy because you can treat them all in the same way. But if people can understand why they have what they have, makes a huge difference, as opposed to bad things happen to me and then I got all these diseases and I went to the doctors and they couldn't help me. Whereas what I'm doing is I'm helping retell their story. This is amazing, to tell their narrative in a different way. These bad things happened to me. And as a result of that, I got these symptoms. And the doctors couldn't find anything because I wasn't actually physically damaged. These are brain-generated neural circuit conditions that are very real, not imaginary, not in your head, not fake, not because you're crazy, not because you want it, not because it's your fault at all. But that's how the brain works. And the hero of this story is me. I can change this. I can make myself better. That is frigging amazing, that change.
Yeah.
And now you don't have a patient is less of a victim and more of an empowered person, that's kind of empowered patient we love those patients, right? They're the ones who walk through brick walls if they have to.
Do you find it difficult or do patients find it difficult to accept your theories that nothing is structurally wrong? Oftentimes they come in with MRIs saying, oh, look at my disc bulges. They have x-rays of their knees that have some degenerative changes. And, they've been attributing all of their symptoms to these structural problems. And then when you tell them, no, it's actually these neural processes, do you find that they have a hard time sort of making that switch and accepting those theories?
Yes.
And how do you address that? I think that's one of the big challenges of managing patients with pain.
Right. Absolutely. Yeah. Well, first of all, I have people read ahead of time, start to learn about this and start to educate themselves. Number one. Number two, if you can, I don't know if I can say this word on the air, love. If you love your patient, they will be more
likely. It's a 4-letter word, but I think
it's okay. Word, they will be more likely to trust you if you're listening to them, if you're caring about them, if you're saying, look, we haven't been able to fix this problem, and I know you're suffering, and I feel horrible about it, and I want to do anything that I possibly can to help. And there's this new research and new treatments that have come out that seem to have incredible promise. And I don't know. I just want to know if you want to look at it. Maybe you want to read about it. Maybe you want to watch some videos, see what you think. Let them choose. Let them come to you. I don't want to sell them something because people back away from that. I'm not trying to convince them of something. I want to investigate with them. And that gets into our diagnostic approach.
Yeah, tell me about that.
Yeah, so the diagnostic approach that I've been working on for 20 years now is obviously we want to rule out a structural problem. I'm not saying that your lupus, I'm going to talk you out of it, or your rheumatoid arthritis. Although the brain can influence the immune system, but let's just put that aside for a moment. But if I've ruled out a structural problem, then I'm going to show them the data to say, gee, what percentage of people your age have bulging discs and have degenerative discs with no pain? Let's look at the data. right? It's 80% in 50-year-olds, right? So it's normal. Everybody has it. I do, you do, we all do. I show them my MRI, it's horrible. So there's some education that's going on there. But once you've ruled out, then what I want to do is I want to rule in what I would call a neural circuit or a neuroplastic problem. How do you rule it in? With careful, detailed history. Does the pain ever shift or move? That's the beauty of fibromyalgia. That's what makes it so easy. It's moving around all the time.
All the time.
So how can that be a structural problem? If you break your arm, the pain doesn't move to the other arm, right? So and they're going, yeah, that's right. Why is it moving all over the place? Well, I can explain it to you, right? That makes sense. Why is it inconsistent? Why does it hurt sometimes when you sit in the chair and other times it doesn't hurt when you sit in that chair? Why is it triggered by the wind, by cold, or by heat? Or why is it triggered by stress? And then they begin to see that in their own life. And why did the symptoms start or get exacerbated when, your dad died? And, I had a patient, I don't know why I'm just thinking of this story now, but she was a young girl, she had SI joint pain, right? And the SI joint pain, we could talk about that. I'm not a big believer that the SI joint does a lot, but whatever. Anyway, so she had this pain. It started in May, and then it went away for a while. And then it started in May the next year. And her dad was sitting there in the room. And I said, that's really interesting. I wonder, you had the symptoms start, this low back pain, in May. And then the next year you had it start again in May. Did anything happen in May, in your family or in your life? And they go, no, I don't think so. I go, okay. And I just waited, and a tear rolled down this girl's cheek. And a tear rolled down her dad's cheek sitting next to her. And her sister had died in the month of May, the year prior.
Oh, my goodness.
To that. And now you have an amazing moment, right? And we talk about gratification and being a doctor, right? How many times in a doctor's career does the patient come back and say, doctor, you saved my life, right? This happens every day for people doing this work. And you have these moments of epiphany, and the patient all of a sudden flips, and all of a sudden you're aligned and you're on the same team now. And when you have doctor and patient alignment, you know what the problem is, you agree on the problem, you're agreeing on the solution, amazing things can happen.
That's a very powerful story. So it sounds like with both the history, ruling out structural disease, is there a role for laboratory workup? Do you ever get CRP? We love the CRP here in rheumatology, to make sure it's not an inflammatory arthritis or...
Absolutely. I want people to be worked up, I'm not a fly by the seat of my pants kind of doctor. I'm not like everything is mind body. No way. That is the last thing I want to do. Now, on the other hand, just because someone has a high SED rate, a lot of people have high SED rates and don't have pain. A lot of people have high CRPs and don't have pain. That's why I want to get the detailed history of what I call functional, the pain is in a widespread area, inconsistent, is shifting, moving, turning on and off, goes away when you're on vacation, comes back when you come back to work, or triggered by innocuous stimuli. So that's what I'm doing. And then I'm understanding that stress activates the exact same part of the brain as does a physical injury. And I'm understanding this concept of predictive processing, whereas it turns out our brain generates what we see. We don't see with our eyes. We all know that. We see with our visual cortex. We don't hear with our ears. It has to be transformed. And when you touch a hot stove, it's not your finger causing pain. It's actually the brain. So when you think of it that way, the pain that occurs that's due to stress or emotions is exactly the same. Every bit as severe, every bit as real, every bit as severe as the pain that occurs with a kidney stone or a fracture or whatever. And that is really, I think, really important for us to understand if we're going to see people with pain.
Yeah. And then, as part of the diagnosis, what's the role of the physical exam? Back in the 90s, the American College of Rheumatology recommended, those tender points.
Right.
And then I know more recently they've gotten away from that. And in rheumatology, we do touch the joints to try to figure out whether there's, inflammation in the joint. And my challenge with patients with chronic pain is that often wherever you touch, including the joints, are tender. So how does the physical exam either help to rule in or rule out a diagnosis of chronic pain.
Yeah. The thing I love about this work is it makes me feel like a mini Osler. It's like you go back in time and I'm doing detailed history and detailed physical exam.
Wow.
I'm touching people and examining them and looking for these inconsistencies. Like with touch, I do this all the time, and I call this provocative testing. So someone has a tender spot, and I'll say, does it hurt with light touch? Okay, well, if it hurts with light touch, allodynia, then that's a neural circuit problem by definition. So I explain that to them because I'm touching your skin. There's no cut or bruise here, so it can't be caused by a physical problem. Just the light touch means it's neural circuit. And then let's say they have pressure with deep, not light touch, but with firm pressure. So I'll press firmly and I'll say, does that hurt? Oh yeah, that's tender. And I'll say, okay, I'm just going to rest my finger here. Now I want you to close your eyes and imagine me pushing. And guess what happens?
What happened?
It hurts.
Huh.
And it's, again, these epiphany, amazing moments where we go, oh, that hurt? Yeah. Why did it hurt? Because your brain is afraid of touch. This is a learned response, a conditioned response. And now we're getting that buy-in, we're getting that understanding. And then I can show you videos of this, videotapes. This is amazing.
So if you could share all of this,
Yeah,
we can put it actually on our website and have it as a resource for people listening to the show.
Yeah, and I've got some on my website. This whole process is actually described on my website, videos. Anyway, so then, say, okay, it hurt when you imagined touching firmly. Now just close your eyes and tell yourself you're okay. You sound so silly, so stupid. I'm safe. I'm not in danger. There's nothing wrong here. This is just my brain. I'm going to be fine. Now imagine me pushing again. And now it doesn't hurt.
Huh.
And I go, you just changed a neural circuit in your brain. That's amazing. You're really good at this.
It's
It's
great.
so much fun. Just the physical exam and doing that kind of thing. When I was in med school, my mentor was this older doc, Dr. Clapper, who he could percuss with his ears blocked because he could feel the percussion.
Oh,
He was like a
interesting.
master of physical exam, and I just think of him all the time.
That's amazing. So it sounds like you make your diagnosis sort of excluding the structural, you do the history, the physical exam, you consider getting some blood work. And then you said that the most important part for patients is sort of education and understanding. In addition to the things that you're doing in the exam, what resources are you providing them that help them to sort of buy in to the story?
Well, first of all, I developed these 6 animated videos. They're like 5 minutes each. And they're in Spanish and English, and I think somebody's turning them into German now, whatever. Anyway, and so there's these animated videos that people can watch that explain this high-level information about what pain is and how the brain works. And then I'm telling people these stories, what happened, as a guy with a nail in his hand, he had no pain at all. How could that be? Because the brain controls pain. This guy had the nail in his boot. That story? He's a British guy, right? He had the nail all the way through his boot, right? And he had severe pain. They rushed him to the hospital. They give him IV pain medication. And then the nails between his toes, there's no injury. And it's like, oh my God, but that's real pain, right? And I tell him about triggered pain and conditioned responses. There was a guy who got pain when he heard a helicopter, which because the pain occurred when he was in Vietnam War and he got shrapnel
wow.
and he got helicoptered out. Telling him all these stories and having him, read some of our books. We have a professional organization, the ppdassociation.org, and there's a patient-led group, tmswiki.org, that there's tons of information about this and stories and people who got better because we want to give them hope. We want to explain that the brain is producing pain, that they're not actually damaged. There's hope for reversal, not just coping with your pain. Because so many of the treatments that we have, particularly the psychological treatments like CBT and mindfulness-based treatments and ACT that are great treatments. There's nothing wrong with these treatments. But they start from the premise that will help you cope with your pain and live with it better, function better. And, people don't really want that. They want to get better. And in our Boulder back pain study, which is amazing, where we use...
Yeah, talk a little bit about that. That's a fascinating study.
Right. So it was in JAMA Psychiatry, published last year. And or was it early this year? I don't know. So we had is in Boulder, Colorado. Tor Wager, the head of this group there. He's at Dartmouth now. He's one of the top neuroscientists in the world. He's published in the New England Journal. He's just an amazing guy. And we were able to tack on this study onto another study. So people were randomized to an arm, 150 people, all got fMRI, by the way, pre and post. It was an amazing study. People got a third got treatment as usual, a third got.
These are patients who've had chronic
Yeah.
long-term back pain. That was, I'm guessing that they had disc bulges
Oh,
and
yeah.
osteoarthritis in the back, and everybody said that it was structural, right?
Absolutely. They had average duration of pain 10 years, over 10 years,
Wow.
the average duration of pain. And I evaluated, the second group got placebo back injection. Actually, it was an open label placebo, whatever. That's what they wanted to study. The third group got our Mindbody treatment, which was pain reprocessing therapy, which is to help people understand that they're not damaged, to lower the fear, to calm their brain, to engage back in activity without fear, with empowerment, with joy, to move with joy as opposed to moving with fear, changing the neural circuits in the brain. And I evaluated all of the people in one branch of the study. I got a license to practice in Colorado for the study. And of the 45 I evaluated, 43 were definitely non-structural. Now, of course, their MRIs were abnormal. But history, the detailed history, ruled in a neuroplastic pain or primary pain. And, whether they believe me or not. But then the therapists were amazing because the therapists get them to start looking at it and doing these little evaluations. What happens when you think this? What happens when you move here? What happens? And that they start to see it. It's not that we're telling them that, we're actually showing them, right? And the outcome was 75% of the people who got this treatment, of the 44, 33 were pain-free in 1 month.
That's incredible. And people that have had pain for 10 years.
Yeah, exactly. And that was 66% of the intention to treat analysis, 66% of the 50, only 44 got the treatment. But anyway, still 66% of the 50 is pretty remarkable. And another study done by Mike Danino at Harvard, your neck of the woods. Mike did a study, a similar study, smaller study, but again, he had 64% of people becoming pain-free with chronic back pain. And it was, again, a randomized controlled trial. And the intervention group, the comparator group, was a mindfulness-based treatment. And I've been a mindfulness teacher for 22 years, and everyone should learn mindfulness. So why doesn't mindfulness? Because we use mindfulness. We use it because we help people to calm their brain in the face of pain. But the first thing is we've recategorized the pain to being a non-structural pain, so they don't have to fear it. Because when you do mindfulness for your back pain, you're assuming, everyone would be assuming, there's something structurally wrong with you.
Right.
And so you're observing it, but it's not going to go away because you don't have the idea, the concept that you're not actually damaged. So that's a key point that we do. And some people won't get it, don't want to get it, will never get it, and that's the way it is. Anybody who thinks they have 100% results, is fooling themselves, right?
So you feel like some of the patients that didn't get better may not be buying into the treatment? Is that the main reason for treatment failure?
Exactly. That's one main reason. Another main reason is they may have overwhelming issues in their life. They may have had severe childhood trauma. They may have ongoing issues in their life. You're living with an abusive spouse, day in and day out. And your brain is sending off these dangers, going home is dangerous. Every day, going home is dangerous. And your back pain is continuing, or your headaches are continuing, or your fibro pain is continuing, And so people are complex. And the folks we're dealing with, oftentimes, it's given me it's made me a way more compassionate doctor. It really has, because, you listen to the story and you go, wow, one story is, worse than the next.
And in addition to learning about sort of this neurally mediated pain, you mentioned that patients, at least in the back study group, were involved with therapists, right? So is the process of healing, do you think people could do it on their own, or would they benefit from somebody else to guide them through the treatment process?
Yeah, there's a spectrum, and 10, maybe 20% do it on their own.
Hmm.
read the books. Dr. Sarno had people read his book and their pain went away. I mean, this happened all the time. Now, they were a minority, but they were vocal. There's a movie about Dr. Sarno, by the way, called All the Rage, which people should watch. It's amazing. We also have
Okay, will
actually
do.
a documentary that was shot at my hospital with my patients. It's called This Might Hurt.
Yes,
Another
I've seen
resource
it.
for people. You have?
Yes, I actually use your website as resources for patients, and I found it very, very useful.
Yeah, so some people are going to get better on, with just the education and reassurance, but that's a minority. A big chunk is going to need somebody to walk them through it, somebody to take them through it, somebody to hold their hand. And so we've trained, and we're doing trainings for physicians, PTs, nurses, social workers, psychologists, coaches, acupuncturists,
Hmm.
massage therapists. It's amazing because what happens is the people who've had this and they've had severe pain and they were told they were incurable and now they're better, they want to help other people.
Oh,
And they
interesting.
become a coach or they turn their therapy into this work or whatever. So there's a lot of people out there that we've identified and trained, and you can find on some of these websites who are doing this work and can help people either in person or remotely.
Yeah, that's great. So you're going to give us those links so that we could put it on our website. But it sounds like there's tons of patients with chronic pain, and there may not be enough providers that are able to do this type of work. I know that, when I refer patients for therapy, often they do just CBT or they focus on their depression or on their anxiety. But I've found it very difficult to refer people to somebody that knows anything about central pain.
Absolutely. Yeah, that's completely true. And we have a long, long way to go. But there are also some online apps. So the Curable
Okay.
app, the Lynn.health app, the freedomfromchronicpain.com app, SACS has an online program. In
Okay.
Britain, there's an online program. So there's some online resources that people can access that are not super expensive at all that can help guide people through that as well. And I'll give you all those.
That's amazing. Yeah, I think one of the concerns I had with this type of therapy is that, are we leaving some people out? If you mentioned that this may be more common in people that experience, adverse childhood experiences, maybe they may not have the resources today to do some of these therapies.
Right.
People that don't have English as their primary language. Are there also resources that we may be able to provide these patients?
There are some, certainly. My book, Unlearn Your Pain, has been translated in Spanish.
Oh, awesome.
The animated videos that I mentioned are in Spanish. There's some of other people. Dr. Sarno's books are in Spanish. The concepts aren't really that difficult, and it doesn't take, it's not limited. People can get better whether they have high SES or low SES. High quotes, educational intelligence. It's really more the emotional intelligence a lot of times that really makes a difference. But we also just wrote a paper on racism as a source, as a pain generator.
No, no kidding.
That
Yeah.
is under the review process. Maybe I shouldn't talk about it. But anyway, it's under review process now. It's some journal that won't be mentioned. But anyway, yeah, you're absolutely right, because adverse childhood experiences and the cuts, the daily cuts, the micro cuts kind of thing that happen on a daily basis and everywhere, and the polarization we've had, COVID. There's a lot of stuff and anxiety and depression have soared. So if anxiety and depression have soared, which are also what I would consider neural circuit disorders, we
Hmm.
treat those in the same way, then of course, back pain has actually doubled in this country in the past 20 years. And I don't think our backs are actually evolutionarily any different than they were 20 years ago.
It's insane. Yeah. Yeah. And I think I've heard you say that people in other countries don't have the high incidence of chronic back pain like we do here in the United States.
Yeah, it's true to some degree. Back pain is a worldwide phenomenon. If you look at the World Health Organization data, it's the major cause of disability in the world, as is other musculoskeletal pain, migraine and tension, headaches, and anxiety and depression. Those 5 things account for the major cause of not death, but disability worldwide. But there are pockets. And the story I like to tell is I have a friend who was a doctor. He's a doctor here now, one of my great friends and colleagues, but he was a doctor in Iraq and then Jordan. And he told me people never had back pain there. Now, whether they had back pain and didn't go to a doctor or didn't think that that was something the doctor could do anything about,
Yeah.
or if they didn't have pain. And I said, well, they have stress. He goes, yeah, they have tons of stress. And I go, well, what do you think were the manifestations of that stress in your society? And he said there was a tremendous amount of allergies and rhinitis and asthma
Interesting.
and conversion disorder.
Interesting. So it sounds like the development of, once you have stress, your environment determines what part of the body is going to be affected by it. Like here in the United States, it may be chronic back pain. I also heard interesting tidbit about that some countries don't have whiplash, that people get into accidents in other countries and they never develop whiplash because the concept of whiplash doesn't exist.
Exactly.
Even though, the same people driving the same type of cars, getting in the same type of fender benders as we do.
Yeah.
Yet because they don't have the understanding, I may get whiplash, they never do.
Right. And yeah, it's true. And that was done in a couple of studies that were done in Lithuania, comparing the rates of whiplash in Norway versus Lithuania. Those references are in my books. There was also a study where they gave a placebo car accident, where they put people in a car and they made loud noises, and it appeared that they were in a car accident, but they didn't move. It was one of those Disney kind of simulation things. And 1 month later, 10% of the people who were in that study had neck pain 1 month after the experiment.
That's crazy.
And those were the people who had the highest levels of stress and anxiety in their life at the time of the accident. So you see this correlation. And there was a recent study, if we want to kind of jump a little bit, there was a recent study that just came out in JAMA, I believe, that showed that the only predisposing factors that they found to long COVID in people who had COVID was anxiety, loneliness, perfectionism, depression. These were the things that were predictors of having long COVID. And there was a French study which showed that where they had serology on 20,000 people. So they knew who had antibodies and who didn't. And they found that there were actually higher levels of long COVID symptoms in those who had negative antibodies for COVID, opposed to those who had positive serology for having had COVID in the past. And there was another study that showed that people with ACEs, with adverse childhood events, were at higher risk for long COVID. So when you talk about kind of these culturally driven symptoms, it's a fascinating area. And there's some great books there's a great book by a historian named Ed Shorter called From Paralysis to Fatigue, talking about the history of what he calls
hysteria, right?
Yeah. He calls psychosomatic disorders,
yeah,
forms of cultural, or what we used to call mass hysteria. The names really are horrible because people really react negatively to those names, but the phenomenon is very real. And there was the cheerleaders in Buffalo a couple years ago. One kid got tic disorder, then another kid, and another kid. And there were 19 or 20 kids who had tic disorder. It was contagious in this little society. And the FDA came, and the CDC and EPA, and everybody came to test the soil and the water and all this stuff. And then kind of blew over. But the point I want to make, if I can, is that the diplomats in Cuba, people debate about this, but the U.S. diplomats in Havana, we just got back to Havana, and all of a sudden they started getting sick. A whole bunch of them they had to all evacuate. And they were examined by the best doctors in America. And they wrote a report in JAMA about this group of people. And one of the things they said was that these people couldn't possibly have a neuroplastic condition because they wanted to go back to work. And this is not understanding on a basic, deep level the neuroscience and the neural circuit. These are involuntary circuits. These are not people who are malingering, people with fibromyalgia are not malingering. People with irritable bowel syndrome don't want to have it. People with chronic pelvic pain or headaches or migraine, it's not their fault. This is how their brain works. And we have a lot of education to do here, Joe.
Yeah. So, I'm glad you mentioned long COVID because certainly that's currently affecting, literally millions of people across the US and the world, patients unable to go back to work and thinking about disability. So how would you approach this group of patients? Is it doing the same type of work you would recommend for for other patients with pain?
It's the same thing because the symptoms that we see are the same symptoms that we've been seeing for years in fibromyalgia, in chronic fatigue syndrome, in quote, chronic Lyme disease. Now it's Ehlers-Danlos syndrome that people are saying, oh, I have pain all over because I'm hypermobile, even though when you were young, you were more hypermobile when you were 5 or 15 than you are now. But anyway, so again, everyone needs a very careful and clear evaluation. Some people with COVID have persistent heart disease or lung disease. I'm not talking about that. But I'm talking about the people that have mild symptoms, tend more likely to have mild symptoms, more likely to have histories of other disorders. If you look in their life, look at their whole person.
Yep.
Right. And I had this one woman, she's about late 30s, I think. She had long COVID for about a year or so, quite disabled. I saw her once. We did the whole thing. It was a 2-hour visit, but it was worth it because 2 weeks later, she was 80% better.
Wow.
It was amazing.
What'd you do, Howard?
Just the same thing I'm telling you. It was just the same stuff. And it's all in our book. We have books for professionals on this. We wrote a book with Alan Abbas for professionals. It's got another book for professionals we have. I'll send you all that. But anyway, the amazing thing was, this is amazing. Okay, so she had loss of taste and smell, right? I saw her on a Tuesday. On Wednesday, she had loss of taste and smell. On Thursday, she could smell and taste fine. On Friday, she couldn't smell or taste anymore. It went away again. On Saturday, it came back. She could smell and taste. Sunday, it went away, and then finally it went away. But what an amazing, it blew my mind as a physician thinking about how the body works and how the brain works to see this neurologic symptom that seems so involuntary. It is involuntary, obviously, but so neurologic, turn on and off and see it as a neural circuit that's changeable. And that's the message that we have for our patients and our doctors is these people can get better. These neural circuits are changeable. The brain is neuroplastic and never stops being neuroplastic. So, it's really, I think, an exciting field, an exciting time. We just got funded a new NIH grant for this work. We're starting a new PRT study out in Denver with Yoni Ashar. We're working with the Department of Defense. So we're trying to do the research, and we're trying to validate this work. And, if it doesn't work, it doesn't work. We're just trying to be good scientists and follow the data.
So once you make the diagnosis, you refer people hopefully to some therapist that has experience in managing these central pain syndromes.
Right.
So who should be part of the team of these patients? Do you think rheumatologists, should be the ones that sort of own this and lead the process? Should it be the primary care physician? I ask because, many rheumatology offices, sometimes they don't even see patients with fibromyalgia, or if they make the diagnosis of fibromyalgia, they send it back to the primary care doctor. So sort of in your experience, what do you think is the ideal team that helps these patients move forward?
I really think it's not so much the field. I think it's the interest. Like I was saying, you have somebody who's a health coach. They may be way better at helping somebody solve this problem. There's some people who do health coaching. They have no medical training, okay?
Yep.
But they've been there. They've had pain themselves. They've got through it. They know this work inside and out. And so there's a rheumatologist in the Northeast, I think she's in Boston, I can't remember, who took one of our training programs. She's doing this work because she has an interest in it. So she's looking forward to seeing those patients. And then she's finding a way in her busy day to take a little extra time, maybe at the end of the day with a patient a week or a couple patients a week to try to, because she's excited about it and she wants to do it. And, many doctors won't be, but if they can find somebody who is excited about it, it's not like, well, go back to your primary care provider. If the primary care provider isn't interested or knowledgeable about it, that's not going to help. Their CBT therapist isn't interested or knowledgeable about it, that's not going to help. That's why at least they can make the diagnosis, I think, in a caring and compassionate way. They can offer hope. They can explain, how the brain can cause, and in your case, is causing these very real symptoms. And then, there's a list of resources that, we're going to work on and people can look at. At least that would be one model that I think would be a great step forward for a lot of people.
Awesome. Howard, you're making me want to sign up for that course to sort of better help our patients.
We have a training app, by the way. We just launched a mobile app for training physicians and other healthcare professionals that is self-guided, self-paced. It's about 6
Oh, awesome.
hours. And so, yeah, I mean, we're really trying to train the world.
Yeah, that's awesome. Because it seems to me that doctors don't understand this. I can tell you from my experience, I've been treating fibromyalgia, since I started fellowship about, 10 years ago or so. And it's been the disease that I've seen least progress in. And certainly my colleagues, I don't think have any better success than I do. So what do you think it is about sort of recognizing this and treating it that maybe physicians don't yet recognize? Why has it taken so long for sort of your work to be known by other physicians? Where are we failing in the training of doctors that we're not recognizing or we're not able to treat these diseases?
Right. I think it's two things. One is we have not been able to take the neuroscience of predictive processing, and I'll give you some references, articles and books on that as well. We haven't taken that science to the bedside, to clinical training. That hasn't happened. Most people say, what's predictive processing? So that's one thing, that the brain generates what we experience. A mind-blowing concept. The second thing is we've been caught between a rock and a hard place, because what happened, particularly with fibromyalgia, is that people were caught between it's all in your head and you're crazy. You're imagining it. It's not real. And this is really a real thing, but it's incurable. So it's, we wanted to validate patients. We want to validate patients, their experience. That's critical. I couldn't agree with that more. But in the validation, we got away from the negative, the worst thing you can tell somebody, it's all in your head. We got away from that, but we flipped to it's real, but the bad, that's good news. It's real, but the bad news is we don't have a cure for you. And that is depressing. And then people go on the websites and the support groups, and they actually get worse because of this contagion factor, where they actually get worse over time, more fear, more worry, they see more symptoms, they hear more about other things, and then their brain just kind of latches onto them with this spiral of pain, leading to more fear of pain, focus on pain, frustration with pain, which leads to actually more pain, because the brain is then getting these messages of being unsafe. And the being unsafe is actually what's causing the pain in the first place. So it's a really vicious cycle.
So what questions remain unanswered in this whole field of central pain? What are the things that you're trying to figure out and things that you think will move the field forward to give us a better way of managing these patients?
Yeah. Well, like I said, anybody who has 100% success rate is fooling themselves. So there's a lot I don't know, there's a lot we don't know. I really learn every day. I'm learning from my patients. I mentioned there's some new research that we're doing, so we're excited about that. This new grant that we just got from NIH, just announced today, frankly. Actually, I think I can say it. I don't know. they've been under this curtain, like, we think we're going to get it. Anyway, we're looking at mediators and moderators of pain and of recovery. So what actually makes people, why do people get better? What are the mechanisms? Can we hone that more? We did in our Boulder back pain study, Yoni is an amazing guy who ran the study, Yoni Ashar. He just did an interview. He did qualitative interviews with the patients, looking at, like, well, what actually was it? What did you find? What actually helped you the most? And now he's going to do, it's actually been 5 years, he's going to do a 5-year follow-up study. Because the reduction in pain in that Boulder study was persistent pain reduction for a year. We followed for a whole year.
Wow. Mm-hmm.
So it was persistent recovery. So there's a lot that we can learn, a lot of neuroscience.
Yeah, I wonder if as rheumatologists, we're maybe doing a disservice to our patients who come in with some knee pain. We get x-rays, there's some osteoarthritis, and we're like, hey, your knee pain is due to osteoarthritis, and guess what? There ain't nothing we can do about it. It's just going to progress and get worse over time. Maybe we should change our discussions of that because, as you mentioned, most people have degenerative changes either on the back or on the knees or whatever. And most people aren't bothered by any pain.
Looking at the whole person in context and taking a little bit more time with detailed history of what triggers it and how is it inconsistent, looking for the clues that would suggest, because I don't know if it's caused by the arthritis or not just by looking at the x-ray. The x-ray, studies by Paula Creamer show that there's pretty poor, not zero correlation, but relatively poor correlation between x-ray findings and pain.
Yeah. Howard, this has been a most fascinating discussion. I thank you so much for your time. I hope that people listening to the show will access acronair.org, where we'll put a lot of the resources that have been mentioned, including various apps, books, websites, movies that can both help to educate, providers that are caring for patients with chronic pain as well as for patients themselves. Howard, thanks again. This has been great.
It's a privilege and an honor. You did a great job. I enjoyed talking to you.
All right. Thanks. Have a good one.
Take care. Bye.
After speaking with Dr. Schubiner, I have renewed optimism about helping patients with chronic pain syndromes. I now feel better prepared to diagnose them, explain to them what's going on in their brains, and help them on the road to recovery. We've included many of the resources that Dr. Schubiner recommended and more on our website at acronair.org. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find all our show notes for this episode on Apple Podcasts, Spotify, Google Podcasts, Stitcher Radio, and now on Audible and iHeartRadio as well. Remember, our brains actually create what we experience in our bodies. I hope that insight helps you and your patients. Until the next time, stay healthy.
Loved this episode of ACR On Air? Then be sure to subscribe at acronair.org and join us every third Tuesday for new episodes. Thanks for listening.